rigorous methods to explore how people living in developing or emerging countries, again, can be best encouraged to adopt technologies or behaviors. He's been using behavioral experiments to examine how subsidies and information about new technology affect uptake, usage, and future demand. He's been working in Sierra Leone for 3 years, engaged in advising the government on the implementation of development programs, strategies to evaluate program implementation, and the use of lessons learned from these programs.
Thank you, Neela. And thank you for joining me up here, Desmond and Niccolo. So I'm going to be talking about work that's actually joint, but there's different types of institutions coming together. A researcher, Niccolo is as well, but he also represents the International Growth Center, which acts as an interlocutor between, say, research and government policymakers. And then Dr. Desmond Kangbai is our partner and co-author on this work, and he's from the Ministry of Health. And so this morning, sorry, not this morning, it was still afternoon, but on the first panel, we heard some big ideas around vaccine development, distribution, setting up institutions that ensure proper vaccine allocation across the world, right? So I'm going to complement that with a presentation on in the field, like it'll be a much more practical presentation, no big ideas here, but in the field, how does this actually work? How do we get vaccines in the arms of people, right? And I'll highlight the fact that even after you set up big development distribution mechanisms, right, you actually need to solve very practical challenges around last mile delivery to get vaccines in the arms of people. So I'll use the exact same map that Dr. Saad Omer showed you earlier today, right? So this is what I'm showing you: share of population fully vaccinated, and as you saw in his presentation, the share of first doses look very, very similar, right? There is emerging vaccine inequity, and it's really concentrated in Africa, right? And that's one of the reasons that we will, our research site will be Sierra Leone in West Africa. So now zooming in from the continent and the world into what's happening in Sierra Leone. About 23% of the population has received a first dose until now, and only 15% of the population has has been fully vaccinated with 2 doses, okay, or with the Johnson & Johnson. And a lot of these vaccines arrived late. So vaccination rates really have been lagging, and they continue to lag. So now when you ask the question, why are vaccination rates lagging in Sierra Leone, in Africa, more broadly, and low and middle income countries even more broadly, where even though South Asia is now caught up, right, it did lag compared to what was happening in the Western world. Okay? So there are 3 categories of answers that come up. So the first category of answers we heard a lot about today in the panel with Dr. Michael Kramer and Dr. Saad Omer, right, which is about what I'll characterize as international supply chain failures, right, which has to do with the incentives that various countries have in production and then distribution and selling of vaccines, and who's first in line in getting it. Okay, so we talked a lot about this. I won't delve any more into it. So there's the international supply chain issues. And then the second set of issues, when African scholars, policymakers have been complaining about the fact that there have been these international supply chain failures that have effectively withheld vaccines from Africans, right? The counter argument that we already heard again in the earlier panel is that, oh, actually, if we were to send vaccines to Africa, they often don't get used, they get wasted because there's so much hesitancy around vaccines. Okay? Like the CEO of Pfizer, for example, is on record saying things like that. Now, so with Saad, with Niccolo, with many other researchers, whose names you won't be able, there's so many you won't be able to read fast enough. So we looked at this systematically, right? And the way we did it was we asked the same vaccine hesitancy acceptance questions across 15 samples, so 10 plus countries, low and middle income countries in Sub-Saharan Africa, in South Asia, in Latin America, right? And then also asked the exact same question in the United States and in Russia as benchmarks. Okay? And what we learned from all that data, just asking the question about vaccine acceptance in the same way across different countries, what we learned is that in every single low and middle income country we study, vaccine acceptance is actually higher than it is in the United States. and it's much higher than it is in Russia, right? So just on the face of it, just from the descriptive data, it just doesn't seem like this is an important part of the story. Okay? This just doesn't seem right, okay? So in spite of that, we do have to confront the fact that, yes, doses do get wasted sometimes. So where does it come from? Why is it, people who are running pharmaceutical companies, people who are running Western countries, they're not dumb, they're smart people. So why are they claiming that there's hesitancy? Okay. And the reason is that there are problems that might end up looking like hesitancy, but it really isn't. Okay. And that problem is in last mile delivery and access. Okay. So people aren't vaccine hesitant, but they're also not like vaccine eager or vaccine enthusiasts, right? So we collected data first in Sierra Leone before running any trial, right? And our data, like pretty much nationally representative data, shows that on average, it takes a person about 3 hours each way to go to the nearest vaccination center. And it costs about $6.50, right? So when you're asking people in rural areas to spend an entire day, maybe overnight, right? Spend about 2 weeks of salary in a location where they're living on $1.50 a day, right? That's what you need to do to go get vaccinated. Under those conditions, where it would cost 2 weeks of our salary, you and I would not be getting vaccinated. Okay? And so when you have this kind of tremendous acute access problems, right? It looks like hesitancy. People aren't showing up. People aren't showing up because the vaccines aren't anywhere close to them. It's not at all convenient. Okay, and so this is just an early attempt by our team to get vaccines out to rural areas. Like, stuff happens, access challenges are real. These are the kinds of practical problems that we need to address. Okay, so now the other thing that if you look in Sierra Leone, when I'm characterizing it as an infrastructure problem and access problem, there is a lot of variation across districts, right? So the red marks are where we ended up doing our study, where we ended up running trials. But you see that in some rural areas, like a lot of the vaccination rates are pretty high, say in Freetown and in large markets and large towns, right? But they tend to be much lower in much more rural areas. And so when you do see vaccinations, we do have a quarter of the population now having received one dose, 15%. So where is it? How is it happening? So this is something that Dr. Kangbai will talk about later in more depth. But a lot of it's happening to what they call surge campaigns, right? And the surge campaigns are designed around health facilities. So both town health centers, but also what's called peripheral health units. So now the surge campaigns are specific days of the month where many, many doses are available and many people show up at the health facilities and they get their vaccines. So why am I calling it a surge campaign? You see that on a particular day, there are massive increases in vaccination. Okay. Now these surge campaigns are designed around the system of health facilities. This is a map. The dots are the union of like big health centers as well as these peripheral health units, PHUs, right? So they're distributed across Sierra Leone, but they're not providing, getting to some of these health facilities from some of the areas of the maps that's just white, colorless, right? It's difficult, and that's where that 2 weeks of wages comes from. Okay, so what we ended up doing was, we started looking at, okay, in the peripheral health units, right? What is their catchment area? So typically they have the mandate to cover 5-mile radius around the catchment area. So this is just a picture I took in one of the peripheral health units in Port Loko district called Katonga. And so what we ended up doing was we took all these peripheral health units and we drew 5-mile radii around them, right? And then we tried to select to try and understand how to solve the last mile delivery problem. We purposefully selected the hardest to reach areas, right? So the blue dots, which typically fall outside of even the very peripheral health facilities, okay? Now, we couldn't always get it right. So you'll see sometimes the blue dots fall within the 5-mile radius. Why is that? It's because we were using a 2016 list of facilities that was available to us, but by 2022, there were many more facilities that were built. So some are going to be very, very remote, and some are going to be now a little bit less remote, right? But still, I mean, these are all Peripheral health units have the P for a reason. They're already peripheral, right? And we're talking about areas that are not even covered by those types of units. Okay, so that led to, that was our sampling frame. And then we randomly selected a set of facilities to work with. And the blue versus red was randomly assigned to either treatment or control. Okay, so now let me explain to you what the treatments were. Okay, so the control areas, we went and collected data on vaccination rates. We did not do any intervention. And in the treatment areas, we basically enhanced access, right? We took vaccines to those communities. And I'll show you a series of pictures of what exactly enhanced access means, what set of actions you have to take, okay? And then within the treatment, we divided up into two groups where in addition to providing that last mile delivery, we either complemented that with like some door-to-door outreach, like knocking on doors and trying to get people to our temporary vaccination centers. And the reason we did that is that sometimes, there might be a young man who's scared of needles, but wouldn't want to actually admit that in front of the community, right? So it might make sense for us to have an individual conversation where we can work through his fear of needles, right? But then we also noticed that sometimes, if somebody has a WhatsApp, WhatsApp is really dangerous. If somebody has a WhatsApp account, right? Sometimes they get strange information about vaccines and it quickly spreads among his or her friends and neighbors, typically his. And so we also tried a different treatment where we were trying to identify those small groups and trying to counter that kind of misinformation, right? Okay, so I'm going to concentrate first on showing you what the last mile delivery of vaccines means. Okay, and I'm going to just do this in the form of photos. Okay, so step one is that you need to go in to the community, first meet with the community leaders and socialize the concept that we're bringing vaccines. This is why it's important. And we need to get the community together and involved in quickly getting vaccinated, right? So just going in and calling during the day, calling a meeting of the local leaders. And the leaders might be in many different domains, right? Both men and women of the community, okay? So then we asked them, we try to get them or get their blessings, right? And we asked them to then convene the entire community that same evening. We're also trying to do it very cost effectively and efficiently. So everything I'm going to describe to you gets done in around 48 to 60 hours, okay? So we asked them in that same evening to try and convene all the community members to try and have a meeting where we can explain the importance of vaccines, okay? So this is a picture taken that same evening. And why is it in the evening? So after people come back from the farms, in this particular community, that was a sensible time to have this meeting, right? So that everybody is there, or as many people as possible is present, and there's no excuse that I'm working out in the field. Okay? And this is a case where issues might come up because there might be subsets of the community, individual members who are really hesitant about vaccines or think that they are problematic or evil or dangerous, right? And we in some communities, we're going to face a lot of stiff resistance at this stage, okay? But we try to get everybody to understand why we're doing this, why it's important. And so when we say we, these are Ministry of Health, well, they're called volunteers, but they're really like people who work, they're not regular salaried staff, but they're people who work against per diems, okay? And as well as any community health workers that might be in the nearby area. So they're the ones who are leading these conversations. Okay? Yeah, and in this picture that I took, there's a white guy there with the Patagonia shirt, but that white guy happens to be sitting here is typically not there. This is just a piloting. So this is an unrepresented picture with an Italian guy solving Sierra Leone. Okay, joking. All right. So now that we've basically, we explain why we're doing this, and there's going to be a vaccine clinic. Now, the next step is we have to get the vaccines to that community, right? And as I said, these are very, very remote areas. So that picture right in the middle, right, is just a picture from the vehicle as to after you get here, which is already an hour away from the nearest health clinic, you still have a long ways to go, okay? And in lots of places, we, it's only accessible not by vehicles, by things like motorbikes. So our trick for a lot of places was essentially to put vaccines in the back of motorbikes, that you see that green cooler. And then the picture to the left is nurses in the maximum motor price. So you also have to get the professionals who can administer the vaccines out to the communities, both the people as well as the needles themselves, right? And the pictures in the bottom are the peripheral health unit where the vaccine is typically stored, right? That's going to be about often to a couple of hours away. Okay? And I want to also point out, because we're going to be talking about the cost of doing this, that the types of locations where we are trying to cover sometimes are extremely inaccessible, right? So these are pictures shared on WhatsApp with us, with our teams, and they're doing hard work, right? Any of the Ministry of Health staff members who are going out, sometimes they're facing really stiff, just geographic resistance, even before talking to any individual, right? So some places are really hard to get to. Okay. All right, so what's the next step? We set up the vaccine clinic, right? So this is what the clinic looks like, right? So there are nurses, the vaccine's available, and we've, earlier, we did those earlier steps in order to mobilize the community to come and try and show up for this vaccine clinic, right? But notice that it's not just about having a nurse present to just administer a jab. We also have to have, we're connected with the Ministry of Health system. So we have the vaccination cards. So there are other Ministry of Health officials who are also recording vaccinations and giving people cards. And that's also an important aspect of the entire intervention, right? And by the way, the reason why we chose to locate in these very remote areas, our project in these very remote areas, is because the Ministry of Health had their search campaigns around the peripheral health unit. So we talked to them first, and that's also why the three of us jointly are in this stage, right? So we were coordinating with the ministry to locate our study and try things out in the places where they did not already have a plan. Okay, so now we administer vaccine and register people. So the idea is you mobilized earlier, hopefully lots of people show up within that 48-hour period and get vaccinated, and that's going to allow us to be more efficient and cost effective. Okay? And then, as I said, there were these two different like sub-treatments that we tried. So one was door-to-door mobilization. This is what it looks like. Often it's not a physical door you're knocking on, but you're going and talking to people who are at home. Right? That's in one set of treatment, half the set of villages. But the other concern here that I have to point out is that some doors can be very far. Right. So even when you go out to the community and you're setting up in the center of the village, right? And we were randomly choosing some doors to knock on for the purpose of research, right? Like it took us, one of the adjustments we made is that, sometimes we just have to give up on the extremely remote doors because it just takes too long to even get up there. And then the other thing that we did was go to places where there were groups of people, right? That's going to be the other treatment. So in this case, there was a group of men who were working on the farm on a project together, like digging some kind of ditch. So that's going to be our other strategy. So that's what our intervention looks like. So now I can just tell you quickly what the results are and how they compare to our existing knowledge on vaccines. Okay? So we do all of this. Let me skip over this. This is just like the flow chart we use to train people on what we're doing. And this is what the results look like. So in the control group, about in these remote communities, about 7% of people were vaccinated. Okay. And after 48 hours, we were able to get the vaccination rate up to, with the door-to-door mobilization, to about 35% or 32% with the group mobilization. Okay. And so these are, statistically very different from the 7%. Okay. And another way to say it is like regression adjusted, the effect sizes, our treatment effect sizes is getting 27 percentage point increases in vaccination, right? Over through this 48 hours of activity that I just described. Okay. Okay, so how should we think about that? Is 27% a large number or not, right? So here I'm comparing our study effects to, we've quickly done, by the way, all of this is like happening in real time. We had to finish the study just before Ramadan started, just because people wouldn't take a vaccine after, while they're fasting, right? And so we just got the data, and our entire team, many of whom are in the room, they've been working day and night trying to process the data to put this up, including like finding data from other studies, right? So there's a lot of activities, you know, in lot of like vaccine research that are that are based in the United States. Most of these studies are that are about like using a variety of behavioral science and nudges and all, you know, text message reminders or phone call reminders, etc. Right? And so our effect sizes look much bigger than those, right? In terms of percentage point increases. The 27 is much bigger than those. And it's comparable to the closest comparable study is by Abhijit Banerjee, Rachel Glenister, and Esther Duflo, where in Rajasthan, they went out to villages and set up a clinic. So they also did really hands-on, you know, intensive activities in order to get childhood vaccination rate, childhood immunization rates up. And so that's right on top, the Banerjee et al. Study. And that's where they find a comparable effect size, right? So that's in terms of percentage point effects. And then, Uddin et al., that's a study in one particular slum in one sub-district in Bangladesh where they find a similar percentage point increase. Now, when you look at percent increases, so we are basically quadrupling vaccination rates. That's about what happened in the Banerjee et al. Study in Rajasthan as well. And those are the only two studies that get effect sizes this large, right? Now, the second question we have to talk about is that, okay, of course, we're getting much bigger effect sizes, and we do care about this, right? But we also care about cost effectiveness, right? So when you get these small effects in all these other studies, right, it's also not very costly, right, to send somebody text message reminders, etc. Right? So how much does it cost us to get this increase in vaccination? So I just computed these numbers. We have really good numbers on cost because we had a subcontractor who gave us a budget as to how much they need in order to get this get the implementation activities done. And so it per vaccine administered, our cost is about $30. Okay? And I would say this is probably the most hard to reach, most remote rural place where you can get vaccinations out. And about out of 30, about $8.50. So let's say a third of the cost or a quarter of the cost is sort of a fixed cost component, right? Which would sort of come down at scale. But the rest of it is variable cost, which is like the fuel, the vehicles, et cetera, et cetera. Okay? So it's about $30 per vaccine administered. Now, if you compare it to many of the other studies, right? So let's go, I mean, Banerjee, Duflo, Glenister was the closest related study, the India work. So that was actually a lot more expensive, it turns out, right? So for them, it cost $28 back in 2010, which in today's dollars would be about 37, okay? And that was the more cost-effective of their two treatments. And then the other treatment was actually much less cost-effective. But the other thing to bear in mind when we're comparing the costs is that our costs are inclusive of getting the vaccines to people. So it's driving down their cost of coming and getting a jab down to almost zero because it's right at their doorstep, right? Whereas every other, like if you send a text message, right, or SMS, of course, it doesn't cost very much to do a phone call or SMS, but you have to also add the cost of some, you know, the person having to go to the clinic and actually get vaccinated. All right, so let me stop there.
So my presentation is really an intermezzo between the study that Mushfiq has just presented, which is the research part, and the intervention that Dr. Kangbai is about to make, which is about like the policy response. So having been at the interface between research and policy, both professionally but also physically, being based in Sierra Leone and having to interact with Mushfiq and the rest of the team, and also like with Dr. Kangbai, the ministry, and the partners, we thought it was interesting to describe how this study came about, since it has had, it has been generated by a lot of interactions with policymakers, and is not just something that came out of a research idea. So to put things into context, think about the early days of the pandemic, so March, April 2020, where everything was moving fast. The policy response was mostly about the containment of the disease, right? And the cost of the containment, right? So everybody was thinking about, okay, like how can we make sure that we slow down the spread of the virus, but also like how can we make sure that this does not come at an excessive cost? Not surprisingly, not much was known, not much data was available, and most of our interactions with policymakers were about requests that were coming, say, do you have any data about this or that indicator? And at the time, most of the indicators that policymakers were interested about were things like, do people know much about the virus? Like, what are the practices that people are implementing based on the knowledge that they have available? And also, they were really worried about the availability of basic commodities, the price of basic commodities, right? And meals that people were skipping. So having had a lot of presence in the country and conducting study there for over 5 years, we had quite a rich database with contact details for many of the respondents that have been part of different studies. And so we quickly set up an infrastructure that was allowing us to collect data in real time, right? And then we were also making sure that this data was made available to everybody, but mostly policymakers, very frequently. So we were updating all the statistics. And here you see one of the dashboard that we have put online that was updated on a weekly basis, showing the trend of availability of certain commodities, but also the price of certain commodities. Like here, basically you have a scroll menu where you can see like how the trends move. So this was something that policymakers were mostly concerned about, like in April, May, June of 2020. But then as the crisis evolved and as the rumors of a possible vaccine becoming available started emerging, then policymakers like started thinking about, okay, what is the next thing that we should be worrying about, or at least like through the different engagements with the Ministry of Health and in preparation of the vaccination campaign that was about to be developed. Then like the questions changed. And so like we changed also the survey that we were administering, and it became much more about people's attitudes towards vaccine, and also who people trusted in terms of sources of information related to the vaccination campaign. So both Mushfiq and Professor Romer were presenting the study that was published on Nature Medicine, showing that vaccine hesitancy in places like Sierra Leone and in many other low and middle income countries was not that high or as high as expected. And we have kept monitoring the hesitancy or acceptance of vaccine over time from the moment where the vaccine was still hypothetical to the time the vaccine became a reality. So the vaccination campaign started, people started having information about which vaccine was available, right? And consistently, people have been reporting very high acceptance for all vaccines, like all vaccines that were available in Sierra Leone, whether it was the Sinopharm, AstraZeneca, Johnson & Johnson, or Pfizer. But in spite of this very high acceptance, as October 2021, the uptake of those vaccines were still very, very low. In fact, it was below 10%, right? And so we started, basically we had this puzzle where like, how is it possible that acceptance is so high, but the uptake is so low? And at the time, there were all these different hypotheses going around, saying, is it a problem related to the global supply? But in Sierra Leone, it was not really a problem related to the global supply. Is it hesitancy? We say, well, not according to our data. So we started looking more into what was the root of the problem. And as Mushfiq just presented, like we basically realized that at the time accessing the vaccine was extremely costly because it took people the equivalent of half a month salary and a full day of work to reach one of the vaccination center in the country. So at the time, we realized that vaccine equity means something very different in places like, for instance, the US or Europe, where the health infrastructure is very intensely distributed. So like people have much more access than a place where like Sierra Leone, where the health infrastructure is not as accessible, right? And that has really like been the basis of the study that Mushfiq just presented. This is something that throughout the, as the data was becoming available, and again, like we had that infrastructure that was allowing for quick data collection, we put in place people that are also in the room, like Basuda, like analyzing the data very quickly. And we were also like quickly feeding those results back to policymaker through different types of dissemination. We've been engaging with a different infrastructure at the Ministry of Health, like the expanded program on immunization program manager is here, the National COVID Emergency Response, and other key people within the Ministry of Health, but also like all the partners that have been working with the Ministry of Health and the donors, right? And also we've been participating very actively in different technical working group so that we could have all those discussions on a very technical level, because oftentimes there are considerations that go beyond technical. There are a lot of political considerations when you need to decide certain things, right? And now that we have the results from the study that Mushfiq just presented, we are continuing our engagement. And I think that now it's a good moment to ask Dr. Kangbai how this is actually being used or can be used for the refinement of the vaccination strategy for Sierra Leone. And I think the floor is yours.
All right, I'm going to take you through some few slides. And as we have been discussing, as a country, we want to make use of research to make our policies, and we want to see how best our policies could be evidence-based. And since we started this research with the data collection, we have seen that there has been an increase in the uptake of the COVID-19 vaccines. As we said initially, the idea was around hesitancy, that people don't want to take the vaccines. But taking the vaccines to the communities, what happened? People were taking the vaccine. They were more than willing to take the vaccines. Because as we said initially, most of, this is the map of Sierra Leone. Most of our, okay, let me just go briefly through this. This was when we started the COVID-19 vaccination. When countries like the United States started in December 2020, we actually started on the 15th of March 2021 because the vaccines were not available. Okay, so when we started on the 15th of March, we wanted to get the trust of the people. So the first individual that took the vaccine was the president on the 15th of March. He was the first individual in Sierra Leone to take the COVID-19 vaccine. And after when he took the vaccine was then rolled out and people started taking the vaccine. But the uptake was actually very low because all it was about hesitancy. People are not taking the vaccine. We didn't bring into mind that the health facilities in Sierra Leone, we have 1,500 peripheral health units. But these health facilities were created in a way that they could cover a 5-mile radius. But with the increase in population and demand, most of the other communities are left out. Communities hard to reach, as it was shown on the other. So this is like our vaccine distribution in Sierra Leone. We received the vaccines from the international airport, and then they are being distributed to all the 16 districts. And then from the 16 districts, they are being distributed to the health facilities, the peripheral health unit, where also we have a lot of challenges in the distribution of this vaccine because there are some areas that are actually very difficult to access. So these are the vaccines we have received so far. As you could see, in Sierra Leone, we are using 4 vaccines, the J&J, the Pfizer, the Astra, and the Sinopharm. And this is the uptake of the vaccines. And this is what I want to talk about. So looking at this, we see that when we have our surge activities, we are getting high coverage. But without the surge, you could see surge 1 to surge 6. Whenever we have our surge activities, these are activities that are being designed so that we could have an uptake and high uptake of the COVID-19 vaccines. So between the surge activities, people are not going to the health facilities to get the vaccine. It's only when we go to the communities or when we have the surge activities, they come to take the vaccine. So we have learned from this particular research. I always keep asking Niccolo, how are we going to cascade? Because as a government, we are willing, because we have seen that if we take the vaccines to the communities, the people are more than willing to take the vaccines because the cost, because most people are living below $1. How do you expect someone to spend $5 just to take a vaccine, wherein the case fatality of COVID-19 is very low? So that's where, for us as a country, the research is so important to us because we want to use this research to cascade the uptake of the vaccines to these hard-to-reach areas. As it was shown in some of our pictures, some areas you have to cross rivers, you have to use bridges. There are areas that are not accessible by vehicles. We have to use motorbikes. But if we take the vaccines to them, they are more than willing. So the issue of vaccines in Sierra Leone is not an issue of hesitancy. It's actually an issue of how we take the vaccines to the doorstep of our people. And from the findings, we want to use this research to actually improve on the uptake of the vaccine in Sierra Leone. Because the target of the African Union is for us to vaccinate 70% of the population by the end of December this year, 2022. How are we going to get there if we don't take these vaccines to the doorstep of our people? So the way forward is actually taking the vaccines to the community, and then the people will be willing to take the vaccine. Thank you.
Before opening up for questions, I just wanted to make just one summary statement. So where do we go from here? Right? So what's the point of doing a research study like this, and what is kind of the action plan beyond that? Yeah. So research study was in 150 communities. There are many more such communities that need to be covered in Sierra Leone. But as we saw, if you go back to the map of the global vaccination coverage, there's many countries in Africa and sub-Saharan Africa, right, that also needs this kind of increase in coverage, right? And I think some of the problems we just discussed about remoteness, access, the cost of getting to the facility that can have that will have a vaccine available, that's true in many different countries, right? So the point of our research was, one, that the early argument I was talking about, that is it a supply chain failure or is it hesitancy, right? These things are also related. So as Dr. Saad Omer discussed in the first panel, right? If you don't send vaccine doses, then governments don't have an opportunity to engage in the learning by doing and the experimentation that's needed to set up the systems in order to get vaccines in the arms of people or get them close enough such that they can easily get it, right? So definitely the international community has a role to play here, right? We really should not be, using hesitancy as an excuse to withhold vaccines from anyone. Yeah? And the second thing that Dr. Omer mentioned is that that governments are worried about generating demand if the supply is uncertain, right? And the reason is that can cause political problems, right? And another thing is that they don't want to set up the logistics for one particular type of vaccine when they don't know exactly which brand or which type of dose that they will get. Okay, for all these reasons, it's important for us, for the international community, to partner and send vaccine doses. But developing countries like Sierra Leone and others in Africa, they also need to experiment and set up these last mile delivery system, this infrastructure, right? So that's a role that we have to play, right? And what I'm hoping is with this research, we can show that, look, we can actually cost effectively get people even in very remote rural areas to take vaccines, right? And there's a direct implication of that, which is that this idea should be scaled up to reach the rest of the population in Africa, the roughly 75 to 80% of people who still haven't been vaccinated.
Questions now? Yeah.
don't think. Yeah, oh, okay.
Thank you so much for sharing these results, and congratulations on the really promising findings. I was curious, since you mentioned a few times that one of the greatest barriers to accessing vaccines in rural areas is just the cost of transportation. If you considered, when you were designing your RCT, having a sub-treatment around subsidizing that transportation, something akin to no lean season, or even providing a cash incentive to go and get the vaccination at a clinic. Because I wonder if that was effective, how that might stack up in cost efficacy relative to some of the other interventions of having the folks from the clinic go out to the more remote areas. Thank you.
Oh, great. So, and I like the connection to no lean season as well, and seasonal migration. So there, yeah, so I want to explain conceptually why I actually, we thought about it and we opted against it, right? So in the case of seasonal migration, right, the idea was, look, sometimes it's actually cheaper to bring people to where the jobs are, right? Rather than trying to do job creation in very remote rural areas, right? Where, like, for structural reasons, we understand there's no employment during particular seasons because of the nature of crop cycles, right? That's why we went in that direction. Now, in the case of vaccines, it is absolutely true. Transportation cost is very high, but transporting 1 or 2 motorbikes full of vaccines to the village is much cheaper than transporting 50, 60 people individually to the health center, right? That's why we went in this direction.
Hi, thank you so much for this presentation. It's really interesting research. I've also done several studies in Sierra Leone, so it's very nice to see the pictures. I was wondering, of course, it's really great to see the uptake when you actually go to the people. And not to be a total bummer, but of course it was not 100%. So I was wondering, did you hear reasons why people, even though the vaccine was close to them, still did not take them?
Correct. So there are too many reasons. I think that this is something that is also important for eventually the scale up and the increase of the cost effectiveness of the intervention, mostly about the effectiveness side, right? So in terms of reasons for people not taking the vaccine, there are still some sort of normative aspects that are, like, I can tell you the cases that are really, they've really like been driving the uptake down, which is like some community leaders that really discourage the community from taking the vaccine, right? And if you have a person that is in a very authoritative position, discouraging other people from taking the vaccine, then nobody will take it. We had a few of those cases, and unfortunately that really drove the results, like the uptake, very, very close to zero. And so those are the things that we need to consider, like when we are like busy in the next phase or in the scale up. How can we better engage traditional authorities so that there is more buy-in and they would like act as leverages for increasing the uptake. Another thing is that, and this is probably linked to the study that Jason, Laura, and others are doing in India, we have not been incentivizing the vaccination teams, right? They've been paid a flat rate regardless of the performance. Maybe there is also an aspect in getting people to put more effort into, like either persuading people or perhaps working longer hours, beyond the hours of the sunlight to get the uptake higher.
Thank you.
That it's an excellent question, and we might. It's a good idea in future iterations. We might want to try bribing people, or maybe bribing the people who are working with us and administering them in order to get the vaccination rates high. But I just wanted to add to all of that we actually collected a lot of this data. So we have detailed or rich baseline data as to what people's perceptions and of vaccines are, their reasons for taking or not taking it. It's just that we wanted to just put up the treatment effects first, but this will all be coming.
I think we have time.
Hi.
Sorry. Yeah, we have time for one question, and then we have one online question.
Hi, this is Stan Vermund on Zoom. I don't know if I'm next, though.
That's okay, go ahead.
All right. I actually had a question that was a little bit similar to the previous question, which is, you know, you've done community mobilizing, you've reached out to the remote rural areas, you've secured a stakeholder buy-in, particularly from community leaders. And on one hand, 7 to 34% sounds terrific. On the other hand, we're always looking for 85, 90% coverage. And how to innovate at the community level in rural Africa to really reach the ethereal stratosphere. But I have a feeling that the question's already been answered, but if anybody has any other insights, because we certainly have done much better through the EPI in vaccination of children, but obviously here we are trying to vaccinate adults, and maybe folks will vaccinate their children in a way that they won't vaccinate themselves.
All right, I think that's fine. Well, vaccinating children is quite different for the COVID-19 because when we have our routine vaccination exercise, the mother takes the child to the health facility based on the schedule for vaccines. But now the case is different. And also we know the perception about the vaccine, the social media, the WhatsApp, and all the false messages also have an impact on the uptake of the COVID-19 vaccine. So what we have been doing as a country is actually improving and modifying our social mobilization messages, trying to make use of, because in Sierra Leone, we also have something we call the CHWs, the community healthcare workers, where they are attached to communities, and we have also been training them, sending them to the communities to actually engage and sensitize people on the uptake of the COVID-19 vaccine. So those are some of the strategies we have been using, and with the use of the CHWs, the community stakeholders, the paramount chiefs, and all those stakeholders, so the uptake is improving. So with the vaccination, we need to keep sensitizing people because people are always getting messages through social media that are actually totally false. So we need to keep sensitizing them using the structures available, going to the market centers, the religious leaders. Those are the structures we have been using in improving on the uptake of the COVID-19 vaccines.
Yeah, and I'll just add that, I mean, both the last two questions are really important ones, and we're learning from it. And what's going through my head now is, you know, maybe we should, so we kind of picked off the lowest hanging fruit, right? But we did something that only is 48 hours long, right? And so the lowest hanging fruit happens to be like, if you just, there's people who are willing to take a vaccine, and if you just take it to them, they'll take it, right? And then the next, for the next group, we need to maybe do something extra, right? And given that a lot of our cost is just going out to the community, instead of 48 hours, if we just move it to 72 or 84 hours and do this extra push incentive, working with the various stakeholders you just mentioned, right? We might be able to get the cost per vaccine administered down by doing more, right? And the other thing that we look into in our data is that we're going to have large variation in our data, like the 35% we got to was the average across 75 villages, right? There's going to be some 50+% villages, and doing some qualitative work to understand what drives that kind of variation and see if we can learn from the 50+% and try to replicate that elsewhere.
Okay, we have a final panel waiting really patiently, so I'll take one last question and then we will get to them.
Thank you, and I'll keep it short, I promise. Just echo everyone by saying thank you for this great presentation. My question is how in the research design you accounted for the 1 versus 2 dose vaccines, because you were only in the communities for 48 hours. So what did you do if you used, you know, the 2 dose vaccines? Or did you come back to those communities to administer second doses, or did you just leave it at 1 dose?
No, so we some of our vaccines were J&J, so that was the 1 dose, and then, you know, so the other vaccines are, we just did the 1 dose, and we will have to go back after a few weeks delay. You know, like Pfizer has a particular calendar, and we have to go back that way.
So did you account for the second visit in thinking about cost effectiveness of coming back to those communities to administer the second dose?
Yeah, so it depends on what your outcome, you know, the outcome variable right now is getting a dose in, like, right? You can define the outcome variable again as fully vaccinated, in which case I suspect what would end up happening is, you know, for the fully vaccinated outcome, J&J is going to look really much better in terms of the cost effectiveness, just because of the fixed cost of going out to the village.
Yeah, but did you consider the efficacy of the different vaccines though, in like thinking about like fully vaccinated for Johnson & Johnson is different than fully vaccinated for Pfizer, certainly. So I know it'd be like a second level of consideration.
Yeah. So that would require an additional calculation beyond cost effectiveness, which is efficacy per dollar, right?
Got it. Thank you.
Thank you. Thanks.